Hi, my name's Cassie Beisel with the Melanoma Research Foundation. Welcome to our Facebook Live, What is Survivorship? I will be moderating the session today. I am also a stage 3 melanoma survivor myself, so this topic is very, very close and near and dear to me. I was diagnosed in 2011 and have been NED since then. And I'm very excited that we're having this session to talk about it today. I'm also very excited to welcome two wonderful people from Massachusetts General Hospital, Riley Fadden and Leanne Miller with us today. Riley Fadden is a nurse practitioner at Massachusetts General Hospital. She's previously worked at Beth Israel Deacon's Medical Center in inpatient oncology as a registered nurse before becoming a nurse practitioner in 2012. She attended Simmons College in Boston, Massachusetts, where she received her undergraduate and graduate degrees. At a Massachusetts General Hospital, she specializes in management and treatment of melanoma, as well as other skin cancers. Her clinical interests include immunotherapy, toxicity management, and survivorship. She has established the severe immunotherapy complications service at Mass General Hospital, which is a multidisciplinary team that manages complex side effects from immunotherapy and has worked as a consultant for an immunotherapy toxicity app. She also recently started a melanoma-specific survivorship program at Mass General. When she's not working, she likes to spend time with her husband and her dog, Pork Chop, which is an awesome name, by the way, or she likes to knit, which she picked up during the pandemic. We also have Leanne Miller joining us. Leanne Miller is the outpatient melanoma and genitourinary oncology social worker at the Massachusetts General Hospital Cancer Center. She focuses her efforts on helping patients and families process their emotional and psychological responses related to the entire cancer experience. Leanne also supports patients as they navigate the complicated healthcare system and provides access to valuable resources at both Mass General and from other third-party support organizations. Leanne began working in the melanoma clinic in 2017 and recently began working with patients in the melanoma-specific survivorship program at Mass General. Leanne is a licensed independent clinical social worker. She has a master's of social work from Boston College and a BS in animal science from the University of Vermont. And we are absolutely ecstatic to have them with us today. As I mentioned earlier, we're going to be talking about survivorship. And as many of us know, the number of Americans with a history of cancer has gone up greatly over the last years. And according to the National Cancer Institute, there are now more than 15 million Americans living with a history of cancer and over 1.3 million Americans living with melanoma. And survivorship, can have a few different meanings, but to most, it means living with, through, and beyond a cancer diagnosis. To start us off for this conversation, I'd like to introduce and welcome Riley Fadden. Riley?
Hi, thanks for having me. I think, so as Cassie said, she gave a very nice introduction about me. I work at the Massachusetts General Hospital in the Melanoma Center, and recently Leanne and I started the survivorship program there. So we're very happy to be here. I think we were going to start by kind of talking a little bit about some of the facts about melanoma to get those out of the way. And I think that will help just clarify even more why talking about survivorship for melanoma specifically makes sense. So melanoma is the 5th most common kind of cancer overall, and that's pretty obvious with the graphic over there on the right. I think for people who don't have melanoma, that might be surprising because they never hear about it. It doesn't have special walks like breast cancer, or people don't know the colors like prostate cancer and breast cancer, but it's actually one of the most common cancers, top 5. It's the 2nd most common cancer for people aged 15 to 29, which is surprising, I think, to many. Also, I think a lot of tanning, which hopefully has gone by the wayside now, has led to some of those diagnoses in years past. But the important thing on the slides below is just how much the treatment landscape has changed. So I think the slide on the image on the left there shows, which we had to kind of cut off that timeline because really it just would go on forever. But really before 2011, there were only a handful of drugs that were approved for melanoma and the prognosis was not that great. Since 2011, in the last 10 years, you can see, I mean, a dozen different treatments have been approved for multiple indications, both in the metastatic and in the adjuvant setting, which means we can try to be more aggressive about preventing this from coming back. And that translates to better outcomes, which is that kind of graphic on the right over there, that those mortality rates are dropping, which means more people are living with cancer, through cancer treatments, and even beyond. And so it's so important to really talk about what does that look like for one of the most common cancers.
Great. Thank you for that, Riley. That was very helpful. And, considering, so tell me a little bit about what survivorship is and what does it mean for the melanoma community?
Yeah, so I think of survivorship, or my kind of preferred definition of breaking down survivorship is really from cancer.net, which is ASCO's kind of endorsed information, which breaks it down into three stages or phases, which I think is important. And that's the acute, which is from diagnosis through all of treatment, which is a totally different need, coming right off of therapy, ending it, and for those first few months or maybe even year or so after, and then that extended, that long-term remissions, maybe those cures, and what does that look like? Because I think patients can face different stressors financially, certainly on treatment, with their relationships, with their symptoms, and then afterwards, trying to kind of navigate how do I fit back into those things. I think Leanne's probably more qualified to answer some of those deeper, darker feelings because she's the one that kind of asks patients about those in detail. So I'll kind of defer to her on maybe some of the common issues patients tell us about.
Yeah, and I'll just I'll echo what Riley said. I think during the acute phase of survivorship, if you're surviving your cancer, if you have not died of your disease, you're surviving, right? And so there's a lot of these issues that peak up, but they don't kind of really show up until treatment ends and you're left with all this time that you're not in treatment to think about. I think what's really unique to melanoma, and I do work in another clinic, so survivorship shows up in different ways, and Riley touched on this earlier, is you don't hear about melanoma as much. So it does feel a little bit, at least for my patients, what they've communicated to me is they feel a bit isolated in their survivorship journey. So, my role in the survivorship clinic is assessing for that. And then also I joke I'm a professional storyteller to kind of give them a feeling of solidarity with their other melanoma survivors. But I would say the melanoma clinic is unique in that patients feel a bit more isolated as they kind of navigate these survivorship issues, which is relationship with fear of reoccurrence, with the sun, with educating people about melanoma. So yeah, that's what I would add, amongst other things.
Thank you, Leanne and Riley, for that. So, talking about how, melanoma survivors are a bit more siloed or feel a bit more ostracized from the rest of the cancer community as a survivor, why would you say that is? Do you think it's because, I know that a lot of times people think, oh, it's just skin cancer, it's just melanoma, you can get it, you can get it cut off and you could be fine. So, what do you feel are some of the reasons behind that isolated feeling?
Yeah, I think, some of them are definitely the outward physical appearance, right? It also, while the median age of diagnosis is older, it's about in their 60s, 65. Like I said, there's a lot of younger patients, right? And so that doesn't always fit with that typical cancer patient look. And then, we give a lot of immune therapy, targeted therapy, not chemo. So our patients don't have that look to them. We share a suite with even like the GI cancer patients, and a lot of our patients will comment to us, not only just feeling guilty about how they look, how they feel, but just that like, am I as sick? And their cancer could be even worse stage. So I think, that's in part why it's difficult. And then I'll let Leanne kind of chime in so I don't.
Yeah, I would say the chemo versus immunotherapy. Like I've even had patients say like, well, I'm not on, I've had patients say I'm not like in real cancer treatment, like a genuine response where I have to provide education about, yes, you are. I think, there's two responses people get when talking about melanoma, either, oh my gosh, melanoma, are you okay? Or you got it cut off, you're fine. So I think it's lack of education. And with those younger age groups, people are living longer, right? So if you get a melanoma diagnosis when you're 20, you're living a long life with this feeling, whereas not saying it's any better, but it is shorter if you get a diagnosis at 83, right? So, and then the other thing is the different types of melanomas. So for example, ocular, there are some very rare kinds of ocular melanoma. So just, there's a joke with breast cancer, even though, I'm not trying to be insensitive, everybody knows what it is. And there's this solidarity in that. But if you're someone with a rare form of melanoma, it's really hard to find others, and they're out there, and I see them, but we're at a massive hospital where people come from all over. So if you're in North Dakota with a rare form of cancer, it's really tough.
Yeah, and that's actually a really good point about the rare melanomas. And there are 3 subtypes of rare melanoma: ocular, pediatric, and mucosal. And when you're ocular, it affects about 2,000 people a year. Mucosal is 1% of all melanomas, and pediatric, about 500 kiddos a year about diagnosed with this. And so, I don't know how much you guys have worked with some of those rare subtypes of melanoma, but what would you say for pediatric survivors? I mean, that's got to look a lot different than survivorship in even a young adult versus somebody who, that melanoma hits most, like a 50-year-old, white male. So what is the contrast of that, and what kind of are the different issues that they would face?
I speaking from like the developmental standpoint, I think the supports are a lot that they're going to need are a lot different. And I don't work I've shared PD patients, I think maybe 1 or 2, so not a lot. But we're talking about how much do they understand? How old are these young patients? Are we supporting their parents, educating their parents? And Riley can probably speak more to this, but what treatment can we give them? Can their bodies handle? So it's just a whole different set of psychosocial issues. And it's not, it's patient and family, which is true in the adult clinic, but supporting the caregivers and educating them and connecting them in some way, somehow with other people.
Riley, do you have anything you want to add to that?
So I think, even going back just to the slide that I showed you guys in the beginning, like all of those stats are really for cutaneous melanoma, right? And they're not for, the mucosals, the oculars, or even, pediatric. Pediatric melanoma tends to have pretty good outcomes, but mucosal and ocular, I mean, their outcomes are just not as good. It's almost misleading that they're called melanoma too, because they're really 3 different diseases. And so their prognosis, for each one of those is really very different. And so sometimes patients come in and they're excited, I have melanoma and I read the stuff and it's good. And they have one of those subtypes and that's hard, or they already come in feeling just so much more anxious because they've read about it and they know that, that's worse. And then, in terms of the treatments, like Leanne said, just the different developmental stuff. And we don't take care of peds. They're seen on a different, floor, but we have had, unfortunately, several very young patients who are right at that cusp, or 18, 20, 21. And it is a different challenge. They can't go out and do those same things with their friends. They can't go to the beach and just lay and tan. They can't go out and have a drink on some of these treatments. They can, all those things, thinking about their fertility. And I don't know, at 18, do you want to egg harvest? Like all those conversations are just so much harder for those, patients and their subtypes, right? So, for cutaneous, you're talking mostly surgery and then systemic therapies, but for ocular and mucosal, they the radiation is almost always involved in some way. And so that also leaves issues, not just in the short term, but long term. Radiation makes things more, scarring, fibrotic. And so if that's in their sinuses, people can have issues with, all sorts of just kind of congestion and infections and dryness. And same for the eyes, they could lose their eye. That's very disfiguring. And some of the mucosals might be in the genital area, right? And so that's really difficult just in terms of their, sense of self, their body image, all of that kind of stuff. And so, I think Leanne also spends a lot of time talking with patients kind of through this. She does a lot with the young adult and adolescent, groups there too. And they have a whole, there's melanoma of the 3 kinds, and then there's also like ranked by age. And so there's so many different types.
Yeah, absolutely. I would definitely agree with that. And, going through even my years, I was diagnosed when I was 32, and the meaning of survivorship has changed with me throughout the years. And I'm not going to reveal my age now, but the meaning of survivorship has changed with me, especially as I've aged out of that young adult group as well. It's a whole different story. So let me talk about this, because when I was a patient, there wasn't much talked about survivorship in the melanoma community, because as you said at the beginning, back in 2011, when I was diagnosed, there were 2 treatment options, and now we have well over a dozen, and it's keeping going with this amazing research that's happening in the field. So when is a good time, no one ever brought up survivorship with me. When is a good time to bring up survivorship with your medical team, or to even start thinking about what life is going to be like as someone who is surviving? Like, when is there a right time?
Yeah, I think there's never a wrong time. So I think patients obviously can bring it up whenever. And, I think for Leanne and I, because of this program, we're thinking about that more and asking patients. But, especially when patients are on treatment, we're so busy just looking for side effects and problems and kind of managing that we sometimes forget to ask about these things, or, just overall, even just like, how are you doing? We're asking about symptoms, right? But we're not like really deep diving into all those other things. And so, I think it's always a good time, to ask. I think some patients, as they're nearing the end and they know that, will start those discussions. And I think people tend to pay more attention then. But we have some patients who, after 1 or 2 doses are like, all right, so when can I be done? And, like, what does follow-up look like? Like, how much longer do I have to do this? And so the conversations start early for them.
And I would add that a lot of our patients they've never heard of survivorship. And so I think it's about educating providers on picking up some of this language, because I think I identify it, and like, I'm in this amazing clinic that I joke they don't need a social worker because they're all like social worker, hybrid nurse practitioners and doctors. But I normally name it. The patient starts talking about certain issues they're having. And then I think, and the initial diagnosis, I am a newly diagnosed cancer patient. During treatment, I'm on treatment. And then they don't know what word it is to describe where they are now. And so that's normally when the conversation starts, is what you're experiencing are these psychosocial issues related to survivorship. And people respond differently to that. And so I think it's about educating providers about how to identify it, help give them some type of structure to name it, because patients don't even know what they're naming, and people respond differently to it. So, but yeah, I think anytime's appropriate. I think during active treatment, patients are less receptive to it. They're like, when I survive this, I'm not going to care, but once you do survive it, then they come up. So I would say we're still learning how to do that.
Pardon me, I thought I had muted there, but yeah, no, absolutely. So I also just want to remind people before I go on to the next question that you do have the opportunity to ask questions, and we'll leave a couple of minutes for that. So if you want to ask these wonderful women a question, please feel free to put it into the comment section, and we'll make sure to get to as many as we can after this. Let me ask this. So, obviously you guys are in the Boston area, you're part of Mass General, which is a large system. And we do know that, as melanoma is more well known and the incidence rates unfortunately keep going up, there is more need for that survivorship conversation. What do you say for people who don't have access to a large survivorship program or any type of survivorship program from like a large institution that might be like Massachusetts General or something like that? How can they get going with the conversation of survivorship?
I think a lot of the, nonprofits obviously have a lot of information. So obviously MRF and, there's a lot of other resources like that that are available that I think have good and real information and not just like somebody's blog that is, voicing an opinion, but really information about that. And then I think the major players are really obviously their oncologists, their oncology team, whether that's with a nurse practitioner, social worker, nurse, any of those things, and their primary care doctor. So I think a lot of people sometimes during treatment think we're their PCPs, which is not always true, and we don't, we're not qualified to be their PCPs. But having those discussions and figuring out, so much of survivorship is getting back to preventative health and being kind of their best self. And so have they been, kind of lacking on mammograms or colonoscopies? Have they, in metastatic treatment, did they see a dermatologist, or was that gone to the wayside because we didn't know what the prognosis was? So getting all those things. So I think kind of identifying who those players should be, certainly their team, but the other, probably doctors and NPs that have to be pulled back in.
And I'd also add just briefly, even if you're not treated at one of these like major hospitals or in a city, I always tell patients, like, even if you're I'm from Wisconsin, so I joke, like, I don't know where people go for treatment because I don't know where I would go in my hometown. I encourage people to go to these, MD Anderson or, Mass General or Dana-Farber, go to their websites and just reach out to any of their social workers, their melanoma social workers. It happens to me all the time. And I will then refer to bigger organizations. So just because you're not treated somewhere doesn't mean you can't reach out. And most people have their names and their contact information. And then, so I would start there. So even if you're not getting treated, maybe reach out to one of the social workers from a major hospital and see what resources they have. They'll talk to you. If you reach out to me, I'll talk to you.
I might just do that one day, actually. Survivorship is such a big topic and there's so much to go over. And unfortunately, we only have a small amount of time today. So we can't even really dig into the whole core, which is, there's so many different side effects that happen. But what are some of the most common trends? And I don't mean trends in, popular trends, but what are some of the most common, I guess, areas that you see identified, or some of the issues, I guess, that you see identified within survivorship for the melanoma patient, outside of the obvious, the obvious running things, getting back into work and stuff like that. But what are some of the things that you see that are more unique, I guess, is the best word for it, for the melanoma population?
Yeah, I think obviously one of the backbone of melanoma treatment is immunotherapy. It's something that all patients are eligible for, regardless of their tumor type or mutations or whatnot. So we use a lot of it. And so there's so much about the immune system and gut health. And so I think a lot of our patients are really hungry for information about nutrition and the microbiome. And, there are always fads that happen. And right now, even outside of cancer, like the microbiome, I feel like is always everywhere. And there's a million commercials about probiotics, which I'm not advocating for, but just people want that kind of information. So I think almost every patient in our survivorship clinic has asked for more information about diet and things they should be doing like that they can change. And then I think some of the, kind of residual dry mouth, maybe, dry skin, but those things that might not always kind of go away as quickly, joint pains, from immune therapy that linger. So some of those things that can be chronic or permanent, which is unique to immune therapy.
And I'd add, along with all of that, is this relationship with the sun. And melanoma can come from a lot of different places, but people associate it often with the sun, and sometimes it's from the sun. The sun's everywhere you go. So that is, and a lot of the time these patients of mine loved the sun. They spent their life in the sun. So how do you, with a lot of the cancers, there's ways you can kind of control your coping by different diet or exercise, but with the sun, it's everywhere and it's triggering for patients. So that is unique to melanoma. And how do you manage that in a world where the sun is everywhere you go?
That is a really good point, and that is absolutely very true. And as someone myself who is a very large outdoor enthusiast, I struggled and grappled with that for a really long time, and I'm sure so many others do that enjoy being outside as well. But again, just a reminder, part of surviving with the sun, I guess, is using the tools that you have in your toolbox to help prevent. And that is, wearing, the SPF. So covering yourself, reapplying every 2 hours, making sure you get that shot glass full, covering up with UPF 50 clothing, not being afraid of the sun and kind of reimagining what your relationship with the sun is going to look like, but making sure that you have that full toolbox through and you're going back for your skin checks over and over again. And, another thing that I think, and I'd love to get both of your opinions on this before I go to quick questions, but, and getting basically, I think, and I just lost my train of thought, and this is part of survivorship right here, guys. I just want to tell you that the memory kind of goes, and there is that brain fog and cancer brain and everything like that. And I unfortunately lost my train of thought with that. So I'll just have to move past that question. But before we go to questions, any last minute thoughts that you want to let people know about survivorship in melanoma?
I would, if there are resources available to you, I would just encourage you to access them. I had a patient earlier today say, like, I feel so pampered. This feels extra. I almost feel like I'm asking too much. My cancer's all better. And now I have, just ask if the resources are available, even if your cancer is no evidence of disease and you're in this phase, there's a lot more to it. And so definitely access those resources if they're available to you, and don't have any guilt about that.
I agree with that. I think many people obviously don't want to ask for quote unquote help or assistance. But all of those, I've never had a patient say gee, I wish I, didn't talk to the social worker, or I wish I didn't talk to a nutritionist. That's my biggest regret on treatment. No, everybody enjoys all of those things. So I think asking about those, and asking other team members about just other patients, right? I think people are really interested in that. How are other people doing a year out? Are other people as worried as I? Just kind of it's okay to ask in comparison, because I think that reassures people a lot that how they're feeling is actually pretty normal.
And then I just remembered my thought real quick. So, and before, I let everyone go, two things. I'm going to ask my question, but I also want to let you know that there was a really nice comment that somebody said, this is extremely interesting. And as a Scottish skin cancer nurse, it's amazing to get another perspective. So we do have people listening from Scotland. We also have some people listening in from Australia, which is wonderful that we're getting that reach. But the other question is, what do you have to say about survivor's guilt? Because it is a real thing, and there are people who survive, and there are people that unfortunately do not do as well with the disease. So what do you say to those people who suffer from survivor's guilt, who think that maybe mine wasn't oh, I was just stage 1. And I didn't go through much, and they kind of downplay their right to survivorship. What kind of advice do you have for that?
I think I would validate that experience. It's a part of surviving, of course. So I always encourage patients to find, if you are experiencing survivor's guilt, locate a social worker in your clinic or a community therapist to talk about it. Where's this guilt coming from? And almost in a way, my patients who experience it, it's like their way of honoring those who didn't have the outcome they did. And then I have patients who find really beautiful perspectives through that conversation, whether that's, hey, some people didn't survive this, and I bet they really hoped that they could have, and if they had, they'd be living their lives. So people find different ways to rationalize it. So I would encourage someone, if you're having survivor's guilt, A, it's completely normal, and B, find someone to have a conversation with about it, because it helps.
Those are great last words. Find somebody to help is the best thing you can do. And if you don't have a large program or any type of survivorship program, please feel free to visit melanoma.org, and we can make sure to get you hooked up with somebody through our partners at Immerman Angels that might be able to talk about similar experiences with you. Also, just make sure to visit our Melanoma Research Foundation survivorship resources. You can find those at melanoma.org. And again, I know we're just hitting the surface of survivorship. It goes so much deeper than what we skimmed through today. But I feel comfortable knowing that there are amazing medical professionals such as you, Leanne and Riley, to help us get through the confusion of survivorship and some of the anxiety and fear that can come along with it. So we're very appreciative to practices like yours that have done that. And we're, again, very grateful for you. So thank you so much for joining us both today. And we hope that we can continue more conversations like this in the near future and continue these wonderful, great conversations. So thank you so much. Bye, everybody.